Good afternoon, everyone. It is 12 o'clock, so we are going to go ahead and get started. Thank you for taking the time to join us for today's webinar hosted by North Carolina Medical Group Management Association and the North Carolina Medical Society Foundation. My name is Danielle Snyder, and I am with the North Carolina Medical Society Foundation welcoming you today. We're thrilled to have you joining us. As a reminder, the North Carolina Medical Group Manager Association mission is to maximize the value and effectiveness of medical practice leaders through educational programs, information exchange, networking, and professional development opportunities. The North Carolina Medical Society's mission is to provide leadership in medicine by uniting, serving, and representing physicians and their healthcare teams to enhance the health of North Carolinians. We have enjoyed our collaborations with these monthly lunch and learn webinars we produce for our membership. And in each of our shared educational opportunities, we embody these two missions, this digital meeting being no exception to that. Today's presentation will be focusing on a legislative update. Throughout the presentation, please feel free to submit any questions in the chat box. We will also have time if you'd like to raise your hand and speak your question out loud. We will have time for that as well. We do ask that you please remain on mute during the presentation to minimize any background noise. We are recording this presentation. It will be made available to you after today's session. As you know, since March 30th, the Medical Group Managers Association and North Carolina Medical Society have been working together to gather essential information so that we can pass this along to you all. And without further ado, I'd like to introduce our speaker today, who is both a resource and a good friend to the Medical Society, Dave Horne. Dave was recently named Lawyer of the Year for the Raleigh Government Relations by Best Lawyers. He manages the government relations practice at Smith Anderson and leads a team of professionals in the firm's corporate relocation and expansion practice. Dave has spent nearly 30 years representing private interests, including many nonprofit associations, medical groups, and businesses, before the North Carolina General Assembly and other state and federal government entities. He's been rated in the top 20 of more than 700 lobbyists registered in the state by an independent survey of his peers, the press, and legislators conducted by the North Carolina Center for Public Policy Research for more than a decade. After receiving his bachelor's with honors from the Methodist University, Dave has spent several years in business, returning to law school and receiving a JD from Campbell University with distinction. His law practice experience includes serving as an associate general counsel and state legislative director for the North Carolina Farm Bureau Federation and its affiliated entities, which include the largest domestic property and casualty insurer in North Carolina. He has also served as Director of Government Affairs for the North Carolina Bar Association for 5 years. Dave, thank you so much for being here with us today, and I will turn it over to you.
Well, thank you, Danielle, for that kind introduction, and thanks to each of you for attending the webinar today. We hope to provide you interesting and useful information in your practice. I am fortunate to be joined today by two of my colleagues at Smith Anderson. First, Robert Shaw. Robert is the leader of the healthcare practice at Smith Anderson. He has extensive experience in healthcare regulatory matters, mergers and acquisitions, and has an extensive tax practice in addition to his healthcare practice. So we are most fortunate to have Robert leading our healthcare team. He is familiar with healthcare not only because of his understanding of the law and the regulation of this sector of the economy, but also his father's a retired professor of pulmonology at East Carolina, or was at East Carolina University School of Medicine. And his brother is an ophthalmologist who practices in Greenville. So he has an understanding of medicine, not only based on his law practice, but his family relationships too. And so we're fortunate to have Robert, who will talk with us about the new rules governing surprise billing as a result of federal legislation. Robert will be with us for the first segment of the program and will have to leave by 12:30. So if you have questions on that part of the presentation, we ask that you provide us those questions, or raise your hand or send the question in the chat during Robert's presentation, so we can allow him a chance to respond to that. In addition, we have the good fortune of having Josh Grant. Josh is our Director of Public Policy and Government Relations at Smith Anderson. He is a veteran of the North Carolina General Assembly, having served on the staff of one of the leading budget writers in the Senate. He is a graduate of Southeastern Seminary, as well as the University of North Carolina at Wilmington. And so we're very fortunate to have Josh as one of our team members on the Smith Anderson Government Relations practice area. So our next slide, I just want to give you a brief overview before I turn the program over to Robert. You see on your screen the topic that we hope to cover during our 1 hour webinar. First, we'll lead with the federal surprise billing rules, which many of you, I'm sure, will find interesting, and those very important, particularly in a number of practice areas. We'll move from there to the developments in North Carolina this past year, in the principal areas where the medical society focuses its time and energy, advocating on behalf of members, the physicians, as well as physician assistants. So principal areas of liability, healthcare insurance coverage, the regulation of healthcare, scope of practice, as well as public health issues and access to care issues. And finally, we'll end this program talking about how you, as a medical society member, or as one that serves medicine through the business aspects, that is running a practice, managing a group, how you can make the medical society and the medical profession an even more effective advocate in the public policy space. And so with that, let's move to my partner and good friend, Robert Shaw.
Great. Good afternoon, everybody, and thanks for joining. As Dave said, I'm Robert Shaw, and I'm here to talk to you about the No Surprises Act, which is a very significant piece of federal legislation that's going to be effective as of January 1st of next year. So coming right upon us. The No Surprises Act addresses balance billing, or sometimes called surprise billing, an area that's gotten a lot of press attention in the last 5-10 years. Horror stories of somebody goes to the hospital and ends up with $100,000 bill and so forth and so on. Those kinds of stories are what the impetus for the No Surprises Act. A balance bill, just to briefly refresh, is an unexpected bill from a healthcare provider, and it's when a person that has health insurance unknowingly gets medical care from a provider that is out of network with their insurance company. So in that circumstance, it's not uncommon that the out-of-network provider will send the patient the balance of the bill from what the insurance company pays. The No Surprises Act addresses balance billing in the context of services that are provided at a facility as defined in the Act, and that's primarily hospitals and ambulatory surgical centers and similar institutions. The current pattern in North Carolina is if a provider is out of network and provided services at a facility for which that provider bills directly, and it doesn't go through the hospital's bill, then the claimant goes to the health plan. The health plan pays the out of network rate, and then the provider may bill the out-of-network patient, the patient, the remainder of the bill. And sometimes you try to negotiate the out-of-network rate with the provider, and sometimes you use what's called the patient protection law in North Carolina to require the insurance company to pay the balance of the billed charges. That's the law that has reigned, especially for insured claims in North Carolina for going on 20 years or more. And that law is probably going to be rendered obsolete in most circumstances by the No Surprises Act. The No Surprises Act replaces that entire regime with a totally new approach. The patient's cost-sharing obligation is sent by the insurer to them is based on what's known as the recognized amount under the law, which is the same as the qualifying payment amount in North Carolina. So there's a lot of complexity in this law. It's 1,500 pages of regulations, and it's a fairly extensive statute too. So we'll try to boil it down and move this right along. But the qualifying payment amount for our purposes is what really matters. So that is based on the median contract rate that's recognized by the health plan as of January 31 of 2019. So that reaches back a couple of years and within the same geographic market. And so the qualifying payment amount, practically speaking, means you pick the median rate for your area for that insurance company as of January 31 of 2019, going back to a few years, and then you carry that forward rate using an inflation adjuster to the current year. And that's the amount that you're paid under if you're out of network with the insurance company and you provide services at a hospital or other facility. So that takes the patient out of this dispute between the out-of-network provider and the insurance company almost entirely. Essentially eliminates their having to face a balance bill or anything of the rest of that. So that, I think, is genuinely lauded by all sides in this situation. And if the provider is, under the No Surprises Act, dissatisfied with the qualifying payment amount, the provider can object to that amount. And that triggers a 30-day negotiation period with the insurance company, where you can negotiate what the appropriate out-of-network rate should be. If after 30 days that negotiation period is not successful, then the arbitration process starts. So there's a 3 business day period in which the medical practice and the insurance company pick an arbitrator. If they're unable to select one out of the approved list, then the HHS will pick one for the disputing parties. Then you have 10 days after the selection of the arbitrator to submit your proposed rate and all your supporting information, your argument for why you believe the rate should be higher than the qualifying payment amount that's paid by the health insurance plan. And then the arbitrator picks the offer that is closest to the qualifying payment amount, unless there's a clear reason to choose a different rate. And that's what's colloquially known as baseball style arbitration. So the arbitrator can't split the baby or pick a different amount. The arbitrator has a pretty simple choice: pick the insurance company's proposed number or the provider's proposed number, and then the arbitration is done. That's the end of the process. It is fast. That is a really fast arbitration process, and it's relatively simple in the adjudicatory standard that the arbitrator has. Now, that's the controversial issue here that's recently come up in the last month or so. The statute had a long list of factors that the arbitrator could consider, everything from the experience and the training of the healthcare provider to the payer mix, the geographic region, and a number of other factors, the complexity of the service. A lot of that is sort of funneled into the strong preference, as stated in the interim final rule, for the qualifying payment amount. Now, that is the issue that is being disputed by the American Medical Association and the specialty associations right now, trying to change HHS's position on that critically important issue. I'm skeptical that they will change HHS's position. Our sources are saying that they think the HHS is kind of dug in. So that means that they will probably file suit to try to overturn that regulation as inconsistent with the text of the statute. I would expect that challenge to be filed in the DC Circuit before the end of the year. But for now, the regime is the qualifying payment amount is going to be the amount that is going to largely govern an out-of-network balance billing situation. The AMA's, I'll just touch on the AMA's concerns and then move on. I know we've got a really full agenda here today. The AMA is concerned that the interim final rule defines the geographic region really broadly. That basically allows the insurance company to rely on its own contract rates, potentially aggregating different regions. Maybe some urban and rural regions get mixed into a given Medicare-based geographic region, which puts everybody on a more unified track, maybe fair to some or beneficial to some and not beneficial to others. It's sort of an inflexible rule. It also importantly reduces the risk of bonuses or risk sharing, value-based care payments, incentive-based compensation, all of which is really important to compensation these days under value-based care. And so right now it's just the fee-for-service rates. As value-based care payment becomes more the standard, it seems likely that this rule will have to be adjusted to account for the reality. That's how health care is increasingly being paid in the modern age. And so for those reasons, you can guess that there will be additional rulemaking in the future on this issue. This isn't the last that we've heard on it, but for now, that's the rule. There can be significant compliance burden on medical providers as well as part of this rather complex regulatory regime, and that's another complaint that the AMA has. So,
hey, Robert, sorry to interrupt you, but we do have a question that's come in. Question from Sherry Raymer. I'm assuming that this would apply to endoscopy centers since ASCs are included. Is that assumption correct?
Yes. Well, it's an ambulatory surgical center, which endoscopy centers generally are. It says described in the Section 1833 of the Social Security Act. So I believe that's generally going to encompass most endoscopy centers.
Great, thank you.
Just to put a bow on this, the North Carolina law that we are familiar with, the Patient Protection Law 58-3-200D, is largely going to be irrelevant as a result of the No Surprises Act in most people's estimation. There may be some dispute about that, but the No Surprises Act is it's a really comprehensive regime. Josh, can you go to the next slide? See if we've this is the you see the text of the law in terms of what the qualifying payment amount is, because that's really the bottom line. The median contracted rate for the same or similar service in the specified geographic area, which is based on Medicare geographic areas. So if there are any other questions, I'd like to entertain them. If not, I'll turn it back over to Dave.
I am not seeing any further ones at the moment. Just a reminder to everyone, you can go ahead and put your message in the chat box and we'll make sure to get those answered for you, but I don't see any more that have come in as of yet.
Robert, thank you very much for that concise but yet informative summary. So we'll move from the federal legislation to what's going on at the state level. Our General Assembly, which convened on January 9th, continues to meet over 150 days in session already. And we're not expecting adjournment now for, well, we'll know later, perhaps even today, when this session might adjourn. It will depend on some factors that having to do with the state budget. North Carolina, I think, is the only state in the country that has yet to enact a budget for this biennium, but that could change very soon, and we expect that to happen. The Senate and House released their budget yesterday. Just as a reminder, though, of some things that have happened, positive things that have happened, you will recall the Medical Society promoted or advocated for and received a $5 million appropriation from the General Assembly, federal money, relief for COVID. And in the next slide, you'll see that there was a $25 million appropriation that the Medical Society was responsible for through its foundation for administering grants to assist independent practices as they struggle with COVID. But what's being considered today, and the governor has a press conference underway even as we speak, is the a 450 plus page state budget. The conference report for that budget was released last evening around 5 o'clock. Governor Cooper, Senate President Pro Tem Phil Berger, and Speaker of the House Tim Moore have been in the process of negotiating that conference report. And there have been many issues on the table of great importance to the Medical Society, its members, and to the patients that its members serve. The governor, as I said, the governor is announcing today, we believe he will announce his intention on this compromise, whether or not he will sign this budget or ask for further changes and choose to veto it. The Josh Grant, who worked with us, who worked for the General Assembly, who now works with us, is a veteran of the budget process. And so we've asked him, and he spent much of the evening last night combing through this almost 500-page document to identify some of the priorities that the Medical Society membership cares deeply about. And he's going to share with us some of the good things that we see in the North Carolina budget proposal. So, Josh.
Thank you, Dave. It is exciting to be with you today. And as Dave mentioned, the governor began a press conference at noon today and has in fact announced that he will sign the budget that has been proposed as a conference budget. So as much as you can't tell, that is a great deal of excitement for us. I think there's, as the governor said, there's a lot here that he supports. He did indicate that there are provisions that he does disagree with and will choose a different avenue to contest those perhaps in court. But as Dave mentioned, let me give you a quick landscape. As the state budget is essentially one of the greatest responsibilities of any legislature. For context and the length of session, Governor Cooper released his recommended budget back in March, toward the end of March, looking to spend a little more than $27 billion in the first year and $28 billion in the second year of the budget. Several months later, in June, the Senate went first this year and passed their proposed budget, spending a little less at a little more than $25.5 billion and 26 and a half in the second year of the budget. Notably, the governor did include Medicaid expansion in his budget. The Senate only chose to extend Medicaid benefits to eligible postpartum mothers. And so once that process was adopted, the House then took up their proposal, adopting it on August 16th, again, to give you an idea of how the year has shaped up. And then subsequently, as Dave mentioned, the legislature released their conference budget yesterday. And as he mentioned, with the many pages, we have spent time seeking to review that on your behalf. As Dave mentioned, there were some items, and you'll see on the screen, of interest to the medical society and the medical community. One of which was the $1.5 million for statewide telepsychiatry program. That was something that was included in the chamber proposals. We also see the $4 million for loan repayment for clinical professionals. The medical society received, or will receive rather, $1.5 million for the Foundation for Children with Neuroimmune Disorders, with a continuing medical education component there. We also see an emphasis on vaccination efforts, a large investment there by the legislature, more than $100 million. With review to local health departments, we see again a large investment there of $36 million to be spread out across the state. We also see school psychologists, an increase there as we recognize that there has been a need in the school system, both from recognized from a school safety perspective, as well as the needed resources coming after the last couple of years. We also see funds for food banks totaling $40 million, and much awaited funds for the Brody School of Medicine at ECU, looking at a $75 million investment over 2 years for the new medical school. Another item that was of great interest to both the House, the Senate, and the governor was broadband spending, recognizing that many parts of the state are underserved. This was an area where many federal funds were able to be used, and we saw a rough number of a little more than $950 million to be spread out over a number of programs to again begin to meet those needs, and something that will also benefit the medical community as well. As I mentioned before, Governor Cooper did include Medicaid expansion in his proposal. Unfortunately, that was not something that was included in the conference budget. However, we do see a few provisions that do make some small changes to the program. Again, extending eligibility for certain pregnant women. We also see the parental eligibility when a child is in foster care. And as Governor Cooper mentioned in his press conference, again, just a few minutes ago, recognizing that there's also a legislative study on healthcare to look at expanding access and Medicaid expansion. He naturally would wanted to have seen that to have gone further. However, again, this is a step in the process, recognizing that it is a continuing conversation to take place. And last but not least, again, amongst the many items that are mentioned, we see funds for substance abuse, recognizing that the opioid epidemic still persists. We see funds to expand the community supervision pilot program. And so that's of interest to a number of folks as well. So pausing there, I'll turn it back over to Dave to look at some legislative matters.
It was a question about the Brody School, Josh. What is the funding for the Brody School earmarked for?
Is for the provision, or the language in the budget was simply for the funding for the construction of a new Brody School of Medicine. The total amount authorized for the project is $215 million. But again, this looks at $21.5 million in the first year and $53 million in the second year. So again, additional funds will be needed, but that's, again, with regard to detail, they're a bit sparse in the budget.
So the expectation is that this is the beginning cost for constructing a new school of medicine. That's what we believe this money is for. First and second year appropriations. So good. Thank you very much for that. Good summary. As a reminder, much of the medical society agenda in the public health arena and the access to care arena is informed by the school of the Institute of Medicine's 2030 Healthy North Carolina report, in which certain goals are set for improving the health status of the citizens of the state. So our policy has been, or not, the medical society policy has been guided by that good work. by the Institute of Medicine. Well, let's talk a bit about some substantive issues other than budget-related matters that are always of concern to members of the medical society. As you will recall, early in the COVID pandemic, the governor issued Executive Order 130, in which he provided the maximum amount of protection from liability for treatment of COVID for healthcare providers, that is, individual healthcare providers, that he was authorized to provide through the execution of Executive Order 130. The legislature convened shortly or within a month or two after that executive order, and passed Senate Bill 704, providing liability protection for ordinary negligence for all healthcare providers in their treatment of persons with COVID. The only exception to that ordinary negligence is if you can be liable if you're grossly negligent or for intentional wrongdoing. But the legislature passed a very comprehensive set of protections for healthcare providers, providing treatment in the pandemic for COVID-related illness. In addition, the legislature provided through Senate Bill 118 protection for business owners and others for transmission of COVID. This bill became effective early last year, in 2020, and it will extend through 6 months after the state of emergency ends. The COVID protection for healthcare providers, which is actually more comprehensive, will end, however, when the emergency order that's currently in place from the governor when it expires. Once you achieve liability protections, it's important to remember that the legislature meets every year and can change the law to eliminate liability protections that they have enacted previously. So each year, the medical society and our coalition of healthcare providers face the challenge of not only seeking whatever additional protections are warranted at that time in the civil justice system, but also protecting past successes. And every year we see proposals to change or repeal past benefits or successes that that the medical society has benefited or is benefiting from. This year was no different. There were efforts this year to change what is known as the phantom damages rule. A number of years ago, and in fact, in 2013, the Medical Society asked the legislature to consider a problem that was identified in medical malpractice cases. It manifested itself in other cases too, but it seemed to be most pronounced in medical negligence litigation. And it had to do with what constitutes adequate or appropriate proof to bring to a jury on the cost of health care for an injured party. Is it the amount that a healthcare provider might initially bill for that service, or is it the amount that is required to discharge the debt for providing those services? And what we found in our study, and what lawyers who were defending medical malpractice cases told us, was that the difference between those two numbers, that is what's billed and what's ultimately required to discharge the expense incurred for medical services, is can be quite large and can drive up the cost not only of that particular case, but of the cost of medical liability insurance. And that, in fact, was determined to be the case after careful review by medical malpractice insurers. Before 2013, plaintiffs' lawyers were allowed to offer as evidence the full bill, the full cost of, or the amount of the bill. And despite the fact that the cost or the dollars required to discharge that bill could sometimes or is often substantially less. There was an effort to repeal that law and to go back to the old system. A coalition of businesses as well, led by the Medical Society, was successful in keeping that bill from passing this year. In addition, there was an effort by some plaintiffs' lawyers to advocate for the change, for a change in law to allow the admission of evidence of the amount of insurance that a physician or hospital facility or other healthcare facility, the amount of insurance coverage you might have. That has been determined for a long time to be problematic and an unfair and irrelevant consideration by a jury. Whether or not there's healthcare or whether or not there's a malpractice insurance to pay a claim isn't relevant to whether or not there's actual negligence on behalf of the provider. So that bill stayed in committee too as a result of the efforts of the society and our business partners in that coalition. Finally, there was introduced a bill to repeal contributory negligence. Contributory negligence, we are one of only a handful of states that continue to recognize that common law doctrine, but it is particularly beneficial when there are multiple defendants. It encourages those defendants to be to actually work together in their defense of medical malpractice claims. That bill also did not move this year. So we were most fortunate in dealing with attempts to change the liability in the civil justice system for healthcare providers and other businesses. Other areas of particular interest to members include health insurance. And there were some changes this year, one of which we supported. There were some proposals this year, one of which we supported, one of which the Medical Society and other health insurance or healthcare providers opposed. The legislature passed Senate Bill 228, allowing employers to offer exclusive provider organization benefit plans. This was opposed by the medical community, principally because it creates, we believe, a trap for employers who are unfamiliar with these plans and the fact that it will enhance the insurer's leverage with provider organizations. The bill is effective this year, and it will allow health plans that are regulated by the state to offer exclusive provider organization plans. There are requirements for continuity of care for certain patients, for those in pregnancy, having a terminal illness, those with a chronic condition. The bill requires that the insurer allow that care, the current care being provided, to continue for a period of time. As I say, the law was opposed by the Medical Society, but it passed, and we encourage you to take a careful look at that statute to see what your rights are as providers and to know what the rights of your patients are under that proposal. As insurers, no doubt will begin to offer these plans in addition to plans that they currently offer that have larger networks. Health insurers testified in the legislature that these plans would allow the businesses purchasing them to save up to 10 to 15% on their health insurance cost. And of course, that was the motivation for the legislature in authorizing them. But those savings come at a cost to patients and providers. A bill that we supported, which did not pass both houses, but what did receive favorable consideration in the North Carolina House, was a bill to improve access to care through telehealth services. This bill would essentially require health insurers to cover healthcare services, that is, to pay for healthcare services that are delivered through telehealth, if those same services would be covered under a health insurance plan. As I'm sure you know, North Carolina law does not currently require that insurers cover telehealth services. This House Bill 149 would require that. This is a bill that the Medical Society will continue to advocate for and will continue to work on when the legislature reconvenes in its short session. The bill was opposed by health insurers based on their assertions that this passage of this requirement will increase cost. Our contention has been that this has a potential, properly implemented, to lower cost by improving health and making available to patients expertise, particularly in rural areas of the state, that they may not have ready access to. So this is a matter we will continue, or proposal we will continue to pursue. There was also a change in the CON laws this year. First time in some time, the legislature, in fact, it may be as long as 20 years since the legislature increased the threshold amounts that can be invested in healthcare facilities and equipment without the requirement that a CON be awarded by the state. If your practice is considering an investment, we encourage you to review those new limits that allow higher levels of investment without a CON. You know, every year since I began representing the Medical Society in 1994, one of the issues that we encounter, or issue areas that we encounter, and it manifests itself in multiple forms is scope of practice. Scope of practice is one of the most complicated issues that the legislature considers. It's complicated because it requires an understanding of the complexity of healthcare, the healthcare delivery system, and the education levels and the competence of various healthcare providers, and an understanding of what is appropriate for each healthcare provider to be authorized to do. This year, a bill referred to as a SAVE Act would essentially authorize advanced practice nurses to have independent practice. This bill was opposed by the Medical Society. There were, however, more than 25 sponsors in the 50-member Senate in North Carolina. It is, I will tell you, just as an observer through the years of these matters, you cannot take your place or your position in the healthcare system for granted, or take for granted that your policymakers understand the level of training that physicians get. That's one of the things we rely upon you to do, is educate members of the legislature about the quality of the education and the amount of time and investment is required in order to receive a medical degree. It is different than other providers, and it's the reason that that an unrestricted license authorizes a medical doctor to perform essentially any medical act, because your training is comprehensive. Now, that it's not advisable for any medical doctor to undertake to do that, but that is what your license would authorize you to do. The SAVE Act would dramatically change the regulation of the practice of regulation of advanced practice nurses, essentially authorizing them to practice medicine independently. In addition to nursing, the pharmacist and others, pharmacists principally this year, have been very aggressive in their efforts to change the scope of practice. Introduced by a pharmacist in the legislature was House Bill 93, which would require prescribers to prescribe naloxone with every opioid prescription. That bill passed the House. The Senate, however, has not taken it up, and we don't expect them to. But this bill essentially would substitute the medical judgment of individual prescribers, physicians, substitute the medical judgment of the legislature on whether or not naloxone was necessary for this particular patient. Next, the pharmacist, through House Bill 96, began a proposal, or a proposal was introduced to authorize them to administer all injectable drugs. That bill morphed into something even more aggressive, which would have allowed pharmacists to prescribe 5 different classes of drugs, including all tobacco cessation medications, all certainly other medications that the Medical Society had serious concerns about. After many hours of negotiation, that bill was pared back and changed substantially. However, the scope of practice of pharmacists was enhanced, particularly immunizing pharmacists. Prescribing authority was modified so that only after the state health director issues a standing order for certain medications that pharmacists wanted to prescribe on their own, only after there's a standing order by the state health director can those medications be provided by pharmacists. In addition, that is without a prescription. In addition, the medical board and pharmacy board are required by the legislation to develop rules governing these activities. So that there were substantial improvements to that bill. There were other scope bills, and there was some progress made on the passage of a revision to the regulation of physician's assistants to allow them to practice without a supervisory agreement with a physician if they're practicing, and only if they're practicing in a team-based practice. That includes essentially, the short order description of that is in a physician-owned practice or at a healthcare facility where there's substantial team interaction. The Medical Society also supported the Interstate Medical Licensure Compact. That bill did not pass, but it's one of the many improvements in the regulation of medicine that the society supported. Let's go to the next slide. Medicaid Transformation. I know that each of you are dealing with the changes that are underway there. Rather than address that particularly, I want to make you aware the Medical Society wants to help you in your efforts to adjust to this change. They want to collect information from you about what difficulties you might be encountering in the process, and have on their website a place where you can register those concerns. That the Medical Society is collecting these concerns. They are regularly having conversations with the department, with DHHS, and with health insurers that are providing Medicaid or paying for Medicare services or Medicaid services. And we encourage you to access that avenue to register any concerns you might have. Finally, there was change in the HIE regulation requiring the HIE to provide educational materials about what they do, and to extend the deadline for most providers until January 1, 2023 to sign up for the HIE. Let's see.
Dave, why don't we pause there and take questions?
Thank you.
I am not seeing any questions that have come in yet. I did put a link to that Medicaid Transformation page on the Medical Society website in the chat as well, so people have access to that. But I don't see that I have any questions at this time.
Yes. Well, thank you. And I'm just going to make, we have 6 minutes left, and there's some important things we want to cover about how the society provides you an opportunity to be an advocate for your profession. I will just make one comment about redistricting, and that is the House and Senate have redrawn congressional and Senate or North Carolina Senate and North Carolina House districts. Those have been passed. They are law. You can expect court challenges, but there's not. There are some other details we can share with you about that if you have questions. Some legislators are double bunked. That is, they live in the same district as another legislator, another incumbent, and how those will shake out, we don't know. But those maps have passed and the legislature is ready. Will begin filing for office, or those that would like to be elected to the General Assembly will begin filing for office the second week of December, and primaries will be held in March. There are two people that I want to bring to your attention, though, that are great advocates for your profession. Representative Kristen Baker, a psychiatrist, the only doctor in the General Assembly. She has been, even though she is a freshman in the House, she has performed at a remarkably effective level and is doing an outstanding job for her constituents, and is also bringing the expertise of a physician, and with her knowledge of the practice of medicine, the healthcare delivery system, bringing that to bear on the legislature's consideration of healthcare issues and health issues generally. Secondly, we have in our congressional delegation in North Carolina, serving in Congress, former state legislator Greg Murphy, who is a great help, not only still in North Carolina, but also in the Congress. Let's talk a bit about what tools the Medical Society provides for you to become an effective advocate, to build relationships with your legislators. On the Medical Society website, you will find a summary of all bills that impact health in North Carolina. We tracked over 450 individual bills this year. More than 75 were considered to be critical for those interested in the delivery of healthcare, the licensure of physicians and others, scope of practice, and liability reforms. So that tool is one I encourage you to access and to use to educate yourself about what the legislature is doing. In addition to that, we encourage you to sign up for our action alerts. It's a very simple process. You'll find on our website this tool known as Muster. Fill in your name, address, or name and email address, contact information. Tell us which legislators you know. We will connect you with them. In addition, we have another tool called the Political Pulse. It's a publication that comes out as needed to inform you about important developments in legislation and in politics in North Carolina. And finally, a tool that is essential in modern day politics, the North Carolina Medical Society PAC, Political Action Committee, regulated by the State Board of Elections. It's a transparent process, and from all contributions are reported, and all by those that support the PAC, and all contributions to legislators are supported, and decisions about which legislators receive contributions are disclosed publicly, but are made by a physician board of directors of the PAC. It's an old saying in politics: if you're not at the table, you're on the menu. We need your participation in our legislative program, and we encourage you to be active and access the tools that we have to give you that opportunity. We thank you for your time and attention, and if there are questions, we're glad to try to respond to those. And if questions occur to you after this is over, email us and we'll be happy to respond and provide additional information, responses to your questions. Thank you.
Wonderful. Thank you all so much for a timely and relevant update, as I echo a comment in our chat there. So thank you again to our Smith Anderson team, Dave Horne and Josh Grant, and Robert, who had to leave us a little bit early. That was great information. Again, very timely. At this moment, I'm not seeing any questions. Lots of compliments, but I'm not seeing any questions in here. So just as a reminder to everyone, we did record today, and if you do have any interest in getting a copy, feel free to reach out to us. We will have that available for you. I would like to just once again thank you all for taking the time to join us today. Thank you to Dave Horne, Robert Shaw, and Josh Grant for taking time away from your busy schedule to present this information, and for your support throughout the years for our organizations. This has just been invaluable, wonderful information for our members and our practices. And again, I'm still not seeing any questions. So with that, it is the top of the hour. I hope everyone has a wonderful rest of your afternoon. Happy holidays and stay safe. Take care and thank you.
Thank you.